would I?
Yeah, so we're thrilled to be in the graveyard slot, which I'm sure you are too.
And we're going to be here till 6, so that's all right with everyone, isn't it?
In a really hot room.
Yeah, which is getting cooler by the seconds. So the idea today was, so obviously Louise talked earlier about the knowledge to action framework, which is supposed to be, yes, the golden thread, the Blackpool and the rock, that thing. But we need to try and think about how we use it within each of the areas of programmatic research. So none of it's straightforward because people are rarely doing a project which has a single thing in it. So we need to think through how we use it within each area of programmatic research. And we also need to think how the teams that have been allocated to support the themes in delivering their programmatic research and getting it set up, how we can help. So I think that's the thing. How do we support you? So I know there's something that's called cross-cutting themes and there's something that's called work streams, but in my head, all those things need to be contributing to the work of the theme somehow. And we need to think how we allocate, how we, ask for that, how we allocate that, how we make sure that you're getting the right support, the right input for the themes. So we thought it was perhaps a useful thing if each theme could just take one thing of theirs, go through it using the knowledge to action framework, not giving you too much to do because obviously yeah, it was a week to get one slide together, but just using something that hopefully somebody would know reasonably well so it didn't be too burdensome. So we wanted people to talk through those things, and then thought we could have a discussion about how we can support people. So there'll be lots of teams that will be needing to input. There's lots of staff with different roles. Some have got knowledge mobilisation, some have got capacity building, some have got evidence synthesis, some are evidence for impact. Some are analog to digital and what have you. So we just need to think, what is that? That's something about data, that's something about summarising existing evidence. Yeah. That there may be survey work that needs doing, there may be other things, interviewing people to whatever, but we need to think about how those people do some of now I would say donkey work, but I'm not going to say donkey work. You did mention donkeys this morning, but vital elves work that needs doing. They don't have elves in Blackpool, I don't think, but yeah, so vital elves to help people with the themes, move things forward. So without further ado, we're going to ask Emma from the long-term conditions theme to do hers first. She gets the prize for being the first person to get her slide done. First person to.
Do I need to click something or will it come up? Okay. So for this, I'm starting with the knowledge that was produced from an NIHR-funded feasibility study known as REVERSE. So the study was focused on one core question, which was whether self-monitoring of blood pressure in people with blood pressure in the pre-hypertensive range could self-monitor whether it's feasible and acceptable in real-world primary care. What we learned was quite clear. Self-monitoring works well when it's delivered through general practice. Engagement was strong, retention was high, and there was no obvious harms. But we also learned just as clearly what didn't work yet. So it wasn't operationally feasible in pharmacy or community settings, and overall, the intervention didn't reach people at highest cardiovascular risk. So the problem isn't whether self-monitoring has potential, it's how, where, and for whom it can realistically be delivered. So the next step then isn't just to scale up what we've already done, but to adapt it. So we're using the feasibility findings as a starting point and combining them with stakeholder and patient co-production to redesign the intervention so it can work more widely across primary care and, crucially, so that it's more relevant to more diverse populations. We already have some insight into what may help or hinder that process. So general practice provides strong facilitators in terms of research readiness and infrastructure. But outside of general practice, the barriers are much more structural. So things like capacity, competing priorities, and a lack of systems to support delivery. And these issues can't be solved by simple protocol tweaks alone, which is why stakeholder engagement is central to the next phase. So that leads directly into what we do next. So the feasibility findings will be taken into a co-production event where we'll work with patients, primary care staff and other stakeholders to develop a theory-informed lifestyle intervention to sit alongside self-monitoring. At the same time, we'll co-design delivery and implementation pathways that are actually workable across primary care settings, not just in general practice. So as this work progresses, we'll be looking very deliberately at how the knowledge is being used, and we will know it's being used if the feasibility findings are visibly shaping decisions, how the intervention looks, how people are recruited, how it's delivered, and how it fits with existing services, including the NHS health check. In terms of outcomes, success in the short term is really about feasibility and reach. Do these co-produced adaptations improve engagement across primary care? And do they help us involve groups who were underrepresented the first time round? In the longer term, success means demonstrating improvements in cardiovascular risk-related outcomes, alongside evidence that the intervention could realistically be implemented at scale. Oh, ahead of myself. And so finally, sustainability is being thought about from the outset. Rather than creating something new that sits alongside the system, the aim is to design the intervention so it fits within existing primary care pathways. If it proves effective, that creates a realistic route for embedding it into routine services, for example, through the NHS health check, and for its continued use beyond the life of the research.
I think that's a really nice example of how sort of using this as a cycle now helps you think about some of the other stages. And I guess for me, as I was listening, I was thinking, well, it's got good with co-production. We're talking about how we involve our public contributors, the VCSFE, all those kind of elements, and potentially analog to digital evidence. So there's lots of things that are across, and I think that's what we need to work out within the ARC too, is how we're going to sort of work with that messiness and who's going to do which bits. So I guess for me, it feels like you kind of going back through the cycle again, if you like. You must have been through it for your feasibility study. You've got those results, and now you're thinking what next to sort of restart the cycle. So I think that's a really nice example. Thank you, Emma. Has anybody got any questions around that or thoughts? Or I guess just to pin it on you, Emma, I'm like, what could we do to help you? But go on, you've got a question.
Very easy to have an inequality stance.
Yeah, of course. Yeah.
Then have an impact.
Yeah.
It's involved.
Yeah.
As well. Is that on stage? Oh, sorry. I'll repeat myself.
Yeah.
I forgot online. Sorry, folks. It would be quite easy to add an inequalities lens to each of the boxes, to be asking questions about who's affected. Just, how do we measure it? How do we disaggregate data? Who should we involved in the engagement process now and moving forward as well?
Yeah, absolutely. And I think a lot of these challenges are across projects and across areas. And I think that's the beauty of the bigger sort of system and this infrastructure work, is we can hopefully help each other across the different projects, because it absolutely has got a health inequalities lens. It's almost like all these things you're like, tick, tick, tick. Not that it's a tick box, but in terms of it's a common problem and a common challenge. So in terms of what we can do from a knowledge mobilisation group and theme and supporting you, that's the sort of thing we need to think about. So I think we could perhaps have a look at where, be clear and articulate where you are in that. And I think that also the planning for sustainability and scale up can also be helpful. Like it could be that we could be thinking about the digital element of that as well. That might be helpful in terms of making it sort of more, well, in terms of the funding, but where the direction of the NHS is going. Yeah.
Sorry. Obviously, we can use the knowledge mobilisation to address the inequalities in access as well. So by engaging and involving the right people throughout the process, we can see what the problem is, and we can start those conversations to get them involved in the dissemination, which is the end part of knowledge mobilisation, although it's not the end part, of course, because it's a cycle.
Yeah.
And if we use something like Hyatt, or for equity, we can use that at the start to get people in the room, and routinely have the right discussions, ask the right questions.
Yeah, so the knowledge to action should absolutely be complemented by all the other tools that we've got, of which the Hyatt and all those things. They're not in isolation. But I think in terms of, say, not that I'm a cynic, but a lot, we'll need to get the funding to do the grant application. You need to write that part of your plan. So if we can say how we've done it in those structured ways, it helps you thinking and it helps crystallise that. Go on, Caroline, you want to chip in?
Yeah.
You can come up.
Sorry. Yeah, so I mean, I guess when in ARC 1, I guess to some extent in some of the projects, what we've done is we've collected information. So we've used the health inequalities framework to think about what data was collected so that we would know that we weren't doing very well in terms of recruiting people to studies. But now we know that. Yeah, it was rubbish. It was middle of, white middle class males, wasn't it? Yeah. So we need to build that in from the get-go. But who is it? Who is it? Which teams have the expertise in engaging?
This meeting is being recorded.
Oh.
Who is it that has that expertise? So we can all use the health inequalities toolkit, look at it, think, oh yes, this could have been done differently. But who is it that has that expertise? Who do we go to? And I'm just putting that out there. I don't have any answers to this as such. Maybe Ben does. I don't know. What do you think? Who do we go to? Who is it that has the expertise in engaging a wider society in these things? Sandra?
I'm going to mention about the social network analysis. So this is what we always used to say as public advisors, as we were. We are involved in so many different organisations, and we've been involved in so many member organisations that we worked with outside of the ARC. And I think that was a trick that we missed by not using us more. We wanted to be more involved in the members. We wanted to have more input. And I think maybe one of the other ways is that in ARC 1, we had an academic that was aligned with the member organisation. Maybe what we should do in ARC 2 is also have a public, whatever we call contributor that is aligned. And it could that we then got a different input to find out who may be beneficial to knowledge mobilisation.
Thank you so much. I'm new to ARC, so I'm Axel Kane. I'm new to ARC, and I'm still baffled, I have to say, and I'm a bit overwhelmed as well. So I have to be honest with you. Hopefully, we're talking about the knowledge mobilization framework, etc. But I'm just wondering, who are we trying to get to formulate all those proposals? It's not just going to be us. We are all institutionalized into the language. You guys know what this is all about. When I started in the last couple of weeks, I had a Hyatt to complete. I had a knowledge mobilization framework to complete, an inclusion framework, a public engagement framework. We got to be careful that the people we're trying to, in inverted commas, mobilize, the researchers, the clinicians, etc., they all have to go through this. These are incredibly high barriers by now. We don't see that maybe anymore, but I can tell you as a previous external observer to this is baffling, really. So we need to keep it, I think, accessible, not just to normal people and people of the public, but also to the clinicians and the researchers we want to attract. Okay, so this was just a word of caution, maybe. So.
Completely get it. That's why we talked about acronym overload earlier, and I think that will be some of our job. And so, like Ellie, I was taught, and other people, their job will be to speak in normal language with real people, and not in this academic speak. But then it's kind of being that translator between the two, because to get the funding, we need to speak in the right language, but to get the engagement, we need to speak in a different language. And there's actually lots of different languages, if that makes sense. So it's it is. Yeah.
I guess we have EDI, don't we? We have EDI people.
Yeah.
Yes,
sorry. And
yes, we have EDI people. So is it them that's got the expertise? So is it Pooja and Yaz and
I think that's the thing. There's all the different themes, isn't there, at the minute? And I think even within the themes, there's lots of people. So we need to kind of work together and work out collectively who are the right people for each project and for each level, and also upskill each other, because it can't all be like one person that's like, I know I'm the implementation person, and you're like, oh my God, how many projects can I be on? Like, that's the reality. You get known for something. So we need to upskill others around us so that there's more of us and grow that expertise. So then it links with the capacity building.
yeah. But so that's exactly, I mean, in a way, this is the start of getting, if everybody's familiar with the knowledge to action framework and always putting things in that way from the get-go, then it's easier for...
Yeah, we can have a more of a shared.
We're all talking the same language, and
My observation was that I completely agree with you. People haven't really been using the tools, so there's a certain amount of public-driven refinement of the tools, because our very capable public contributors can help us refine them. And I can also help us to deliver some relatively straightforward training that could be delivered, quite quickly and remotely. So I could help you. We have to remember what ARC's for. ARC is about reducing inequalities, and it's a relatively small investment of time to do an assessment of the inequalities inherent in the research. Compared to the amount of dozens of hours that you spend writing, submitting proposals, and hundreds of hours conducting the research. So I think we do have to kind of fight for it, probably as well.
This route, it's about people in the communities in the North West Coast. Who is it? It's out there that is keen to work alongside our people to ensure that we don't just do it in things of one group.
Yeah, I found with health impact assessment that the public picked up the tools and ran with them very easily. In terms of getting a range of people involved, the public contributors, because of the range of people as public contributors, and there's Corin, and we have ways in. I think I'm not sure we have ways of having a very good representative sample from that, but we do have some ways in already.
Great. Okay, I'm conscious of time, so should we move on to another example? Who wants to go next? As the Clarissa and Ben are two, I think I've got them there. Should we see who's next on the board?
Sunrise.
Yeah. Over to you.
Yeah, so I mean, talking about the tools and how they apply in different contexts, and I guess I was struggling a little bit to think about how we kind of fit this particular example into the different boxes in that cycle. But to give you just a bit of context, what we were thinking about here is a program that is being implemented in Liverpool. It's called the Citizens Advice on Prescription. program, and it basically offers people access to welfare advice through health services. It's quite a big program. It's been running in Liverpool since 2014, and sees about 5,000 people a year. It's quite a sort of big throughput through that program. And we carried out, as part of the previous ARC, an evaluation of that, and showed, through that kind of evaluation, showed that it probably saved the NHS money in terms of preventing healthcare use, and had, at least in the sort of observational data that we were able to use, show that that had some good benefits in terms of mental health and probably saves the NHS money. So thinking then, giving this exercise about a kind of hypothetical situation where other partners in the ARC might want to implement that based on our evidence. Some might say the evidence isn't good enough yet, we need more evidence, and we are putting in a bid for an RCT of the same intervention. Other partners might say that's enough evidence for us to go with. It could be commissioned by local authorities, NHS, could be lots of different partners. Obviously, it's provided by a third sector organisation. So thinking about the kind of problem, the main kind of barrier to kind of implementation with any of those kind of partners will be how are we going to fund it? That's going to be the first question that any local authority would ask, and what should we stop doing in order to fund this? The local authority will probably be less interested that it saves the NHS money, but the NHS might be interested in investing in it. So there's a whole set of questions about who are the different partners involved, what are their interests, is the evidence what they actually need? And it also depends on what's already being provided in each of those settings. So most places will have some kind of welfare advice service that's already provided by the local authority or funded by the NHS. So in part, we might be trying to convince some places to invest and commission a new service. We might be trying to convince other places to adapt what they're already doing based on the evidence. In each place, there'll be a whole kind of set of barriers that are kind of specific to each place and the different partners involved, what their kind of priorities are, what the overall kind of strategy is. I mean, Liverpool integrated care system had a whole set of goals around the sort of social model of health and sort of poverty mitigation. Other places might not have the same priorities. So making that initial case to actually fund the service is probably the biggest barrier. Once it had been agreed to be implemented, that would potentially be easier. But again, what works for Liverpool isn't necessarily the same thing that would work in a different context. So there would still need to be some kind of process of tailoring that to a specific context, which would, again, depend on what other services were already being provided. And then the next kind of steps, again, are even easier in some ways, because we've already set up a whole system for monitoring and monitoring implementation and uptake of the service in Liverpool that we could implement in other places. So there is a kind of program for that, and we have kind of systems in place to evaluate those outcomes as well. So once we were working with another place and trying to implement that, it would be not too complicated to set up those kind of evaluation and monitoring processes. And ideally, that would then expand it to other places. But still trying to think about how, or if there's any local authorities or places out there. Blackpool, do you want to kind of, you've already got one already, have you? It would be great to work with you around that cycle. Questions, advice?
My reflection on going through that, Ben, is you don't have to go through the whole cycle all the time. So it feels like your focus is more on this identifying problem and whether the evidence is good enough.
Yeah.
And also who the evidence is for, and as in who would be buying it, if you like, or commissioning it. And that's okay if that's where you are. You don't like, yes, you've thought it through, which can be helpful to do, but you're on that, and that's fine. That's part of why it can be useful. And if there isn't, you know, I guess, is the no-do gap there, or we still need to do more work? And then if we're not sure, we need to probably hold some event or some discussions to try and work that out, because otherwise, who are you producing the evidence for?
Yeah.
So I think that's kind of quite useful to think that you don't need to do the whole lot all the time.
Different evidence.
Yeah. Has anyone got any questions or comments? Minorities? Yeah, or we can clap. Thank you. No comments?
I was just wondering about the ISAT. Should we be? Oh, sorry. Sorry, my fault. The ISAT.
Yes.
Implementation Sustainability
Yeah.
Assessment Tool.
Because we like to add another one in. Yeah.
Yep.
Bingo. Yeah.
You have had that one already today, I guess. Yeah, not that everyone can remember what they're called. I can't myself. But in a way, to some extent, sometimes that's portrayed as using it at the end.
Yeah.
And I think it's not an at the end thing.
Mm-hmm.
It's something that you should look at as you go along.
Yeah.
I think, and then you're looking to see where you are. So that's, in a way, that's where Ben should be using that to think about where things are at, perhaps.
Yeah. And I think, you know, the reality will be we need to work out how we're going to work as a team, but we're probably going to arrange some sort of drop-in sessions or structured sessions where we'll go through. We don't expect you to be experts in all the tools and know them all. That's what we'll do. But we'll maybe have a conversation with you and ask the questions, and at the end go, da-da, this is what the ISAT shows in terms of where you're at. Does that actually, how does that feel to you then? Does that look about right? Have we got what you've said correctly? And then like go out to other people and check. Because I'm not going to go through all the different domains, but it essentially is the intervention ready for scale up, and what's the implementation and workforce and all those sort of fit. So I think that might be a nice step to do for this project that we could start with.
Yeah, and I guess I was just going to add to that, to some extent, what we're talking about is things we're doing around here. But the whole idea is that we understand where things are at, so we can make decisions about whether to feed things in at a national level.
Mm-hmm.
And so we'll be having discussions at a national level with other knowledge mobilisation people to agree somehow, I'm not quite sure how yet, how you agree at what point something needs another randomised controlled trial, or, you know, is the evidence good enough? Is it ready for scale up, rollout, whatever? Is it there? How do we know? Because I think we've had a whole load of confusion about that in the past. You know, we've been asked to suggest things that are good to go.
Yeah.
And then you suggest something that's good to go, and then people go, well, no, because that we don't have good enough evidence yet for that to be, or we don't know anything enough about the costs or the cost effectiveness or whatever. Yeah. So we've got to understand those things ourselves and discuss them and agree them.
Yeah.
Here. But we need to feed that in at a national level as well, because we need cross-arc.
Yeah. And I think it helps, gives us the language to do that.
Yeah.
If we've gone through some of those processes, because we should be speaking a similar language across ARC.
Well, we hope. Then they'll be using different frameworks with a different acronym.
Yeah, probably. Yeah. Great. Okay, should we move on to Clarissa? Time? That's okay. Oh, yeah. There we go. Right, so I picked dementia education as the problem. As some of you may be aware that there's a lack of adequate understanding about symptomatology, how to care for people within the health and social care workforce, also to understand better about the needs for people with rarer subtypes of dementia, not just older adults with Alzheimer's disease. So, and this is the first time I've done this, so I may have done this wrong, but just bear with me, okay? So we co-produced, in fact, 2 board games, but I'm referring here specifically about the more adult version. So this game is for people aged 18 plus, and we've been using it in the health and social care workforce. We've been using it with the Merseyside Police Force, Fire Department, general public, unpaid carers, to go out there and try and educate people about what is dementia, what can I do about it, how can I help people a little bit better. So we co-produced the Dementia Inequalities game. So far, we've tested the game in over 1,000 people aged 18 plus. That includes about 400 university students from about 6 or 7 universities across the UK in bachelor and master's degrees in nursing, psychology, OT, orthoptics, radiography, physiotherapy, etc. And using the game, so playing this game for up to an hour or so, has significantly improved their knowledge about dementia and their knowledge about inequalities. But it is a very easy way to assess it. We want to find ways to implement this more broadly and also assess this on a more in-depth level. Can it lead to changes in practice? So we use the board game as well because we feel it's something you can just do when you have a lunch break in your care home, for example. It's a 1 hour thing to do, and you can play it at a game that suits you. Or if you look at bachelor and master students, the lecturers, the module leads can say, well, this fits in this practice week of our teaching block, etc. So we've measured the impact of gameplay via questionnaires, but now we really want to take a step further. How can we measure this more broadly? How can we possibly measure impact on how you change your practice if you work in a care home setting, for example, or in domiciliary care? And that's kind of our next step with this. And I think this is this all my bits? No. So what we want to do overall is try and embed this game as a plan of wider workforce training, knowledge upgrading, knowledge skills within the current care workforce, health and social care, but also the future care workforce. So those that are going to university or getting other qualifications to work in adult social care. So this is one of our examples, which I feel is probably the most likely to move towards like implementation so far in our theme. And that's all I've got on this. It's all right. Yeah. I think we just need to get this implemented more broadly. So it is being used by some universities already, by some courses. They are purchasing the game, they're using it. Don't know, good question. We need to sit down and chat about it. But I think so far, this is something in the past 2 years in particular that has come out as something more tangible that we feel we can roll out right now. And hopefully there'll be other things emerging from the social care theme as well. So, yeah.
Any questions or follow up on that?
As the idea that it will be implemented in care homes and other kind of settings.
Sorry. Thank you. So this has been tested and evaluated in over 40 Scottish care homes with an Rich network already. So now we want to see, can this be for good, be implemented and be suggested as a guidance, use this to start off the process of dementia education.
So we could bring together the care homes in the Northwest and get them.
Yeah, so yes,
You're
so
doing that.
Enrich network is really great in the Northwest Coast as well. But yes, care homes, dom care, daycare, etc.
So how do you know it works was the question.
So me. So we've tested it with the questionnaire, so we know it significantly improves knowledge about dementia, significantly improves knowledge about inequalities. And we've also got some open-ended question within the questionnaires, and they said, we'll go back and learn more about this. We now want to make some changes to our practice, but I feel like we need to do a more in-depth evaluation about this to really capture this than the questionnaire pre and post we've done to date, to be honest.
Yeah.
So yeah.
So at the moment you've focused on knowledge as your outcome, not behaviour or practice change.
Yeah.
Yeah.
I'm not sure the question's entirely fair in this example, because obviously this is a developed output product. So art can help with dissemination, but the process of knowledge mobilization should be at the start of design and development, which isn't your fault at all. But
I think it's an ongoing thing, and I think this is just naming it and using a particular process. I'm sure you've been involved in, it's been a process that you've been doing anyway, just without naming it or calling it these cycles. So it's, going forwards, this will be a shared language and a shared work that we'll be doing. I guess the questions for me around sort of scalability, as you've talked about, or adapting to new contexts, because you talked quite a lot about, fire stations versus care homes versus universities. And so perhaps some way of describing those contexts and also thinking about those scalability aspects would be really helpful. Any other comments? No? Have any of the other themes in the room got any examples that they want to talk through, or we think that's a good place today and you're going to send us them after? And or is she going to get, what should we do? Hourly emails, Caroline, till they send them through? Yeah.
We've got a question online from Finos, which is, how does ARC2 KTA prioritize projects or / proposals?
That's a very important question. We don't really know the answer to that yet. Is the thing. I mean, we're supporting existing projects. So part of it is, how is any theme going to decide which projects? And it should all ultimately, as we've said within the thing, is about partner priorities. And we've got some of those that have been set from the outset in terms of that's what we're putting in the bid after a long process around prioritization. But we've also got the caveat that they should be flexible and responsive to change. So we've kind of got this tension there between, well, we've said we're going to do these, but we also want to be responsive. And we've also been challenged with doing bigger, more at scale, impactful projects. So we can't be doing lots of little projects, and we need to think how we can join those up or how we can do some of those more at scale. So I think there's going to be discussions to have around how we decide which projects. And also, just because you start a project, things can also change, and you might get to a certain point and think, actually, perhaps we need to pause this for now because we're going to pivot to this project instead. But that's some of the work that we'll be doing, is how do we, yes, there's a team of us in knowledge mobilization, and there's a team across in every single, one of these cross-cutting themes. But ultimately, we could end up, 80, 100 projects at once, and there's still not that many of us. So that'll be.
Yeah, I think that's probably also where my question sort of like emerges. So I did find, regardless of what I said earlier, I did find the tool really helpful. Actually, I liked it, but not so much because of it allowed me to kind of see the whole the whole kind of circle or cycle, whatever it is, but because I noticed most projects, once they developed, they really struggle then to be implemented because they can't find sites. So they can't find actually not necessarily NHS organizations or so that can actually say, you know what, we're gonna put money where our mouth is, and we're gonna like work with you on this. And my question then is, how do you, if at all, how you can help in that process? So it's actually select, tailor, and implement in the interventions up there.
Yeah.
That is really, really tricky for a lot of people, for a lot of projects. So I just wondered, is that something you can help with, or are we am I in the wrong room?
No.
So
the select, tailor and implement interventions there can also be around implementation strategies, and they should be theory informed, and I'm not blah but yeah, but I think that's kind of what we'll be doing to a degree, is kind of helping to speak the right language, and then linking with the other themes and the networks and the engagement and all the wealth of knowledge that is within the ARC, really. But it's a, you know, the more you find, I don't know about anybody else after today, I'm just like, oh my God, there's so many people and so many projects. So it's kind of, you know, that's our job, is to try and help make sense of that and to work with that. John, Laura, you might.
Thanks, Louise. Yeah, Laura Boland, so I'm with Health Innovation North West Coast, and just a vote of approval really for the model and the team, and just to say it's going to be really important to have a tool like this and to be able to speak the same language and bring people on this sort of consistent journey with projects, because there's a real need and an opportunity for us to work much more closely, and it will really help facilitate that. And for those of you that don't know, at Health Innovation North West Coast, we've got implementation experts working across a number of themes and programs. Many of them align really nicely to the ARC programs. So you've got ready-made sort of network and implementation experts that you can tap into that might be able to help with that local context and assessing those barriers, and facilitators. And we also have an industry engagement team that will be able to help with that, selecting and tailoring your innovations as well. So just using this to bring all that together, I think will be really powerful.
Yeah, because we've got a shared course, haven't we, between the ARC and Health Innovation. So we have got resource specifically for that.
It's going to be great.
Go on, Caroline.
Yeah, it was only just to, pick up the resource thing, because to some extent, a lot of these things rely on people's time. You know, they're going to participate in a game, that's taking your time. You might do it over your lunch hour, but some people wouldn't. You know, all these things have a cost. And I guess that would be useful to know, perhaps from Andy and Valerio, about what, because when we talk about outcomes, often we think about people's quality of life or whether they live or die, but cost is definitely an outcome. I don't know whether you...
Yeah, and implementation cost as well, in terms of the cost for the training and the, you know, whatever else, that has got a cost. And so it's thinking about that as well, that we've quantified and understood that, so that we can bring that into the evaluation or the whatever it is we're producing.
Yeah, because I think that expertise with Andy and Valerio's team is quite important for understanding the implications of some of these things.
Yeah. Great. Well, I don't know about anyone else, but I'm like, it's 10 to.
And somebody mentioned money.
Yeah. So I'm thinking this is a great start of the conversation, but that's all it is the starter that we're all just getting in post. Not everyone's even started in post yet. Ellie's joining the team next week. She's come on a holiday today. That's the commitment we've got. So we will be following up for those themes that haven't give those K2A slides, but hopefully you can see it's a useful process and a starter for 10 for us to try to understand and get a shared language and work out how we're going to work together going forwards. And we're still working it out too. So please, you know, feel free to give feedback, drop us emails if you think about it. We you know, we're just working it out ourselves. So, but I'm really feel in a good place after today, that we've got lots of really important work and the right people in the room to make a difference. Thank you very much.